Okay, so here we're going to talk about our surgical procedures that we can have done. The cystoscopy, that's going to be a scope inserted into the bladder to directly visualize stones. The cystolithopaxy, that's going to be where we break up stones that are in the bladder for getting them to smaller pieces to remove them. The ureterolithotomy, that is the surgical removal of a stone from the ureter. So down here is going to be our kidney procedures. So we have the percutaneous nephrolithotomy. That's going to be a minimally invasive procedure where the stones are removed via a small incision in the back. This often requires the placement of a nephrostomy tube for drainage. A lot of times it looks like just a small tube that comes out that's attached to like the Foley leg bag, and it just kind of lays at the side with your patient. You can pin it to their gown just like any other drain. But that's going to produce like a more concentrated urine that's going to come out of that. The nephrolithotomy is the surgical removal of a stone from the kidney. Then a pyelolithotomy is going to be a stone removed from the renal pelvis. So this one right here, the percutaneous nephrolithotomy, that is going to be preferred for whenever we have a large staghorn calculi. To get that out. Okay, so open surgeries are a lot less common today. The generation before, they had a lot of like it was an open procedure to get a kidney stone removed. A lot more complicated. Okay, so next we have complications from these renal calculi. We're at risk for a UTI just because that stone's gonna be pretty good at bacterial growth from back in urine up. That can lead to UTIs. The hydroureter, that's going to be the dilation of the ureter from obstruction. Hydronephrosis, that's going to be the swelling of the kidney due to the backflow of the urine from the obstruction. And then systemic complications that we have, there's that risk for shock where we're getting septic from the infection. So these will usually be accompanied with pretty severe pain and bleeding as well. Sepsis, so that's going to be when we have an untreated obstructing stone that has infection that can progress to urosepsis. Then also repeated obstructions can lead to chronic kidney disease. Okay. So anytime we have a stone and then we start to spike a fever, our patient starts to get hypotensive, tachycardic, we want to get a hold of somebody because we're getting to an emergency situation here. Okay, the next several are for, it's just one, our nursing diagnosis. So next we have our nursing data collection. We want to take a good health history, get their vitals, have a good temperature on them. Okay, this is somebody that you actually want their true temperature, pain, strain all their urine. Like I said, you have that little like oil change cup strainer looking thing. Then we want to monitor their intake and output and monitor their symptoms they're experiencing as well. Our nursing care, we want to, of course, manage their pain, strain all that urine, teaching good hydration, and teaching how to prevent the stones as well. Alrighty, so now we'll move on to hydronephrosis. So this is when we have an obstruction occurring. So this can be a stone, stricture, tumor, other causes. And this causes the urine to back up into our kidney. So our kidneys are going to enlarge. So we have that distension of the renal pelvis and calces. We get an increased pressure from that, and that pressure damages the kidneys and the delicate nephrons. So next, that leads us to some kidney damage if we aren't treating this in a timely manner. Okay, so the pressure can lead to the kidney damage, and that can potentially lead us to chronic kidney disease. So we want to identify and treat the cause, and treating the cause means whether that's stone removal or relieving obstruction, but we need to relieve that pressure promptly to preserve the kidney function. Okay, so here we have a picture of hydronephrosis. So we have our kind of mild here where we can see that we're starting to back up the urine will back up and then cause the swelling. That renal pelvis starts to dilate. So this is going to be our early kidney swelling. This is going to be more of our moderate. So we have that ureter dilation here now. Our kidneys are visibly going to be enlarged. There's an increase of pressure inside the kidney now. And then our rightmost picture here, that is going to be severe hydronephrosis, where we have a massive dilation of that renal pelvis and calces. We get a thinning of the renal cortex, and here we're at a high risk of irreversible kidney damage. Excuse me. So I want you to know that hydronephrosis, it's a progressive condition, and we want to intervene early before we start seeing more permanent damage. Okay, so signs and symptoms of hydronephrosis, we have frequency, urgency, dysuria, flank and back pain. Our therapeutic interventions here, we're going to treat the cause, so remove or relieve whatever is obstructing, whether that be a stone, stricture, tumor. For urinary drainage options, we want to possibly place a urinary catheter that can help relieve lower obstructions, so like so we can relieve lower obstructions. The stents, that's going to be placed inside the ureter to help keep it open and allow the urine to flow through to the kidney and into the bladder. Then our last option is that nephrostomy tube. So that'll be inserted directly into the renal pelvis through the back for external drainage. Good nursing care that we want to do is prevent kinking or clamping of this nephrostomy tube. Alrighty, next we'll move on to bladder cancer. This is going to be our most common urinary tract cancer. It occurs more in men than women, and it's usually diagnosed around the ages of 50 to 70. So what I want you to know is that, or no, I don't. It's a good thing to know. I forget if you need to know it. So smoking, that's going to greatly increase our risk for bladder cancer. They say that it doubles our risk with smoking. Also, industrial exposures, chemicals, dyes, pollutants, those put us at a higher risk. So our most important teaching point for these patients, our most important modifiable lifestyle factor is going to be smoking cessation. Okay, so continuing with bladder cancer, our early signs and symptoms, often it could just be painless for them, but hematuria is going to be the early sign. Late signs could be pelvic pain, lower back pain, dysuria, or an inability to void. Next, we have the diagnostic test that we've went over quite a bit, okay, and we all have that table to refer back to. So with the diagnostics, it could be cystoscopy and transurethral biopsy, using that to pick that up. Urinalysis, urine culture. We can get tumor markers. I'm not worried about you knowing those, though. You can get tumor markers. And then imaging as well. Well, it's not clicking for me. There we go. Okay, so therapeutic and interventions. So this intravesical therapy, that's where we have a chemotherapy that is delivered directly into the bladder via a catheter. And that chemotherapy is going to help reduce the tumor reoccurrence. Immunotherapy, there's that Bacillus calmette-Guerin therapy. That's going to stimulate the immune system to destroy the cancer cells. It's commonly used for superficial bladder cancers. There's also the photodynamic therapy that we can use. So that uses photosynthesizing drugs and then a laser light to selectively destroy cancer cells. This is often considered for early stage or whenever we have recurrent tumors. We have surgery. The cystoscopy with the pyelogram, with fulguration, that's where we go in and burn off with like an electric current the superficial tumors. The laser therapy that can help vaporize or remove superficial therapies. The robotic laparoscopic radical cystectomy is the removal of the bladder, and if needed, any nearby organs, depending on the spread. Urinary diversion, this is a creation of the new pathway for urine elimination. So with superficial cancers, we can usually treat with intravesical therapy and minimally invasive procedures, and then the invasive cancers will often require a radical surgery with a urinary diversion. So going on to the urinary diversion, for incontinent urinary diversion, they can create a urostomy, so an ileal conduit creation. This is when I pulled up the procedure here. So you take a segment of the ileum, so your small intestines, that's going to be removed, and that's going to be used as a conduit for urine. So the ureters are going to be surgically attached to that ileal segment. And then that conduit, so kind of like a reservoir, is going to be pulled to the skin to form a stoma. And then there's no sphincter control here, so the urine's just going to drain continuously into an ostomy appliance. So this is where you'll see like a urostomy pouch. To collect the urine, we want to teach our patients to monitor for skin integrity around the stoma, and teach our patients proper appliance care and how to look for signs of infection as well. Okay, so this is going to be one of our most common urinary diversion types. It's reliable, so one of those things that it's been around for a long time, but it's going to require a lifelong appliance use. Okay, next is the continent urinary diversion system. So this is less common compared to an ileal conduit. So you have this reservoir that's created from a section of your bowel, and that's going to be surgically constructed inside of the abdomen, and then the ureters are going to join into that reservoir. But instead of continuous drainage, your patient's going to have to do lifelong intermittent catheterization. So the most common type of this is what's called an Indiana pouch, like the state. It uses a section of the ileum and cecum to form a reservoir. There's a stoma that's created in the abdominal wall, but you don't have to wear the bag or anything because you'll have that sphincter control in that stoma. So your patient will just insert the catheter just in and out cath at that stoma. This helps a lot with like having more, what do I want to say? It helps a lot with body image because you won't have the ostomy appliance, and it gives you more sense of normalcy. So it requires that your patient, I've seen these only in younger patients that have, the hand dexterity to do it. You have to have, the motivation to learn how to take care of this thing. Alrighty, lastly, we have the orthotopic neobladder. This is the most common today. I'm actually not familiar with this at all, so I had to look it up. So this is going to be where you create a new bladder from a segment of the intestine. So the ureters and urethra are implanted in this neobladder. And this allows the patients to void through the urethra, mimicking natural urination. So instead of having a stoma at your abdomen wall, you're going to urinate like, usual. So The benefits of this is it provides normal urinary function. Patients, so your younger patients usually would be good for this because it's still going to require some intermittent catheterization if incomplete emptying occurs. So you want this with somebody that has the hand dexterity to take care of it and the mobility to take care of it. And it helps with body image because there will be no external stoma or ostomy or appliance required. Okay, so this is preferred if you have the right patient. Okay. So nursing care of, oh shoot, sorry, I already talked about it. Okay. So the nursing care, you're going to consult your wound ostomy continence nurse, provide pre-op and post-op care. Your pre-op, you're going to want to prepare your patient for these lifestyle changes, body image impact, and the need for self-catheterization. Teach them all of this prior to the surgery beginning. Post-op, you want to monitor the stoma, look at their surgical site, monitor the drain and the urine output. Okay, with the monitoring the urine output, we want to be looking at the color, the clarity, the amount. Is there presence of any mucus or blood? You'll want psychosocial support, so assisting with the body image coping, encourage support groups if appropriate, and then reinforce teaching. So we want to teach them about skin integrity, what to look for on their skin. You want to teach proper emptying, cleaning, fitting of their appliance. The warning signs that we're going to teach them to look for is going to be a fever, cloudy or foul smelling urine, redness, swelling, or any leakage. Okay. Alrighty, so cancer of the kidneys, it's one of the top 10 cancers in both genders, most common after age 55, and men have twice the incidence as women. All of these cancers, I do want you to know, stay very superficial with them because it's likely that there's not going to be many questions about them. I would focus more of your infections, acute kidney injury, chronic kidney injury, continuous bladder irrigation for the TERPs, things like that. I currently don't have any questions on these, so while it's important to look at them, the bladder and the kidney cancer, I think a good test question would be like on one of the like the conduit pouches. I think one of those would be a good question if I was going to create one, but currently I don't have like specific cancer questions. Okay, so take that for what it is. They're not there right now. Okay, so risk factors of kidney cancer, smoking, obesity, hypertension, long-term kidney dialysis, exposure to radiation, asbestos, or industrial pollution. Our classic signs of cancer of the kidney, we're going to have hematuria, dull pain in the flank area, and a mass in the kidney area. This is often diagnosed after it's metastasized. So cancer was one other place, and now it's moved into the kidney. Okay. For our diagnostic test, we can use the IV pyelogram, cystoscopy and pyelogram, ultrasound, CT scan, MRI, renal biopsy. And again, with those diagnostic tests, I would keep it at the surface level, okay? Whatever's on that table is the information you need to know. Therapeutic interventions. So you can have a radical nephrectomy. That's going to be whenever they're removing the entire affected kidney, adrenal gland, the surrounding fats, and sometimes nearby lymph nodes. A nephron sparing surgery, so a partial nephrectomy. That's going to be where you only remove the tumor and part of the kidney. So it preserves the kidney function. So that's often used for your smaller tumors and tumors that are localized. So radiation can be used for palliative care. And what I mean by that, a lot of people do palliative radiation, and it just helps with the pain relief and helps to control your symptoms, okay? So this is not going to be a curative radiation, okay? This is strictly for palliative reasons. The immunotherapy, so it's going to stimulate the body's immune response to fight the cancer cells. You don't need to know the specific immunotherapies that they're going to use. Chemotherapy is usually limited. With renal cancer, it's not very effective. It's going to be used in very advanced cases. Okay, so surgery is going to be your most primary and most effective treatment. Alrighty. So nursing care after these, you're going to have your pre-op and post-op care. Pre-op, teaching your patient what to expect before. Post-op, you're going to monitor the site, monitor urine output. Since your kidneys are kind of like midway up, you're going to be monitoring for signs of a pneumothorax. So since they kind of sit at the bottom side of the lungs during that surgery, they could, incidentally drop a lung. So monitor for shortness of breath, diminished breath sounds on one side. I think there's several like activity slides that are coming up. Okay. As always, look through these. If you have any questions, I'm happy to discuss them with you. Okay. I just think they're better used once you have a good basic understanding of things, going back and using them as a study tool. Goodness. Alrighty, renal trauma. What slide are we on? 117. Okay, so our data collection, we want to look at an injury history. What was the mechanism of the trauma? Was it blunt? Was it penetrating? We want to inspect the abdomen. I'm looking for bruising, swelling, and asymmetry. So the bruising and swelling, we'll often see this in the flank or the abdomen, and that can indicate internal bleeding. Hematuria, that's a sign of renal damage. So we want any trauma patient that comes in complaining of flank pain, we want them evaluated for a renal injury so we can roll out any internal bleeding. Alrighty, next up is polycystic kidney disease. This is a hereditary disorder. It's characterized by multiple cysts inside both kidneys. The cysts are going to enlarge over time, replacing normal kidney tissue. So these cysts are just kind of moving in and taking over. Signs and symptoms, you'll have your patient complaining of it like a dull heaviness or discomfort in their flank or back. Hematuria, hypertension is common due to the kidney damage. Recurrent UTIs from the urinary stasis. What I want you to understand is this is a progressive disease that eventually leads to chronic kidney disease and eventually ends in end-stage renal disease. Okay, so we have no definitive cure or treatment for this. Our management needs to be focused on controlling hypertension, treating UTIs, and slowing the progression. So patients with PKD often have a family history of this, so genetic counseling would be a good thing for these families. Next up, we have diabetic nephropathy. Okay. So different from your neuropathy, nephropathy. So this is going to be a long-term complication of diabetes, both your type 1 and type 2. It's one of the most common causes of chronic kidney disease worldwide. The pathology of this, so we have that chronic hyperglycemia that's going to damage our kidneys' microvasculature. And then these atherosclerotic changes are going to decrease the blood supply. So you have that chronic hyperglycemia that's damaging. So our vessels are going to be harder to get through. So that's going to decrease the blood flow into the kidneys. So that progressive scarring and thickening of the glomeruli are going to lead to a loss of kidney function. So over time, this will develop into chronic kidney disease, which eventually progresses into the end-stage renal disease, which is going to require dialysis or kidney transplant. So what we want to teach is tight glycemic control, blood pressure management. Those are going to be our keys to delaying the progression on this. Alrighty. Well, shoot, I kind of already said the next stuff. Okay, so early we want to control blood glucose and blood pressure, restrict protein in the diet. Later, we can expect to have dialysis or a kidney transplant whenever you progress through that CKD to end-stage renal. Okay. Next up is going to be nephrotic syndrome. This is going to be where large amounts of protein are lost in the urine from the increase of the glomerular membrane permeability. I talked pretty extensively about this in the pediatric one. So our serum albumin and protein are going to decrease, causing edema, ascites, and anasarca. Our liver is going to produce lipoproteins, which is going to make our urine foamy. Immunoglobulins and clotting inhibitors are going to be lost. And the treatment, we want to treat the cause so we can have symptom management, okay? Our nursing care for these patients. So we are going to monitor their edema, have daily weights, do some strict intake and output, measure their abdominal girth, protect that edematous tissue, okay? So we're worried about skin integrity here. We want to prevent infections, prevent malnutrition, and thrombosis as well. So the hypertension is going to also damage our kidneys because of these sclerotic changes. So, sorry, I lost my train of thought. So our high blood pressure is going to damage our smaller arteries and arterioles in the kidney, and that once those vessel walls start to thicken up, that's going to reduce our renal blood flow, and that's going to have can lead to ischemia, nephron loss, and eventually kidney failure. Okay, so therapeutic interventions, we are going to have antihypertensives. We use a lot of ACE inhibitors. If they can't tolerate those, they'll move to the ARBs because they're more kidney protective, okay? And then using the diuretics, beta blockers, and calcium channel blockers as needed. So our goal here is strict blood pressure control to prevent the progression to chronic kidney disease. Okay, a lot of these, your goal is the same, is to prevent them from chronic kidney disease, and a lot of ways to do that is to control the blood pressure. Okay, glomerulonephritis. So this is going to be an inflammatory disease of the glomerulus. So this can be immune mediated. So our antibodies form these immune complexes that can deposit around the membranes of the glomerulus. Okay, so this is going to cause inflammation and damage, making our glomerulus more porous. So when we have this abnormal leaking, we get protein in our urine, the red blood cells in our urine, okay? So this can be acute after an infection. A lot of these infections are after strep infections, okay? It can also be chronic that ends up leading to chronic kidney disease. Your patients can, I don't know if I've ever mentioned this, so if you're dumping out protein, that's proteinuria. If you're dumping out white blood cells, that's going to be pyuria, so PY urea. That's white blood cells. Red blood cells is going to be hematuria, okay? These people have a, from dumping all that out, they have a hallmark, like tea, Coca-Cola type urine. Okay, it's pretty dark due to that hematuria. Alrighty, the causes of this can be an acute post-streptococcal infection, Goodpasture syndrome, which I'm not quite sure what that is, And then chronic glomerulonephritis. I'll take a second and look up what Goodpasture syndrome is. Okay, so Goodpasture syndrome. It is a rare and potentially fatal autoimmune disorder that attacks the lungs and kidneys. Okay, never even heard of that. Moving on. So signs and symptoms of glomerulonephritis, oliguria, just a vocab thing again, that's going to be decreased urine output, hypertension, fluid retention and activation of the renin-angiotensin system, electrolyte imbalances, we're going to see hyperkalemia, edema. A lot of your kidney disease has periorbital edema, peripheral and generalized, and then as with everything else, flank pain. So next up, our diagnostic test. We're going to see an elevated creatinine and BUN. Urine can be dark and foamy. Urinalysis, we can see red blood cells, white blood cells, protein and casts. Ultrasound, X-ray, and then biopsy. So one thing that I want to point out with this is the glomerulonephritis, you have dark foamy urine, and the nephrotic syndrome, you have yellow foamy, okay? So that's kind of a key difference in those two right there. Okay, so therapeutic interventions, most cases of this are going to resolve spontaneously. If needed, there can be treatment, nursing care that you're going to do, take your patient's vitals, symptom support, rest, fluid, protein, sodium, so those restrictions, and then educate your patient on prevention. So moving on to acute kidney injury. So this is going to be a sudden loss of kidney function, and this can be rapid, so over hours, or it can be over several days. So azotemia, that's going to be the accumulation of nitrogen waste products, so that's going to make our BUN and our creatinine go up, okay? Oliguria, that's the decreased urine output, so that would look like less than 400 milliliters in a day. So the mechanism of injury, we have a hypoperfusion. This is considered pre-renal. This is going to be due to dehydration, shock, heart failure, or blood loss. And then our direct tissue injury, so this is intrinsic. So when we have that acute tubular necrosis, this could be from nephrotoxic drugs, rhabdomyolysis, or infections. Or it could be from hypersensitivity, so an allergic or an immune reaction. Okay, this is usually reversible. Once you identify the cause, you can correct it, and then the kidney can bounce back. So with these patients, we always want to be monitoring their urine output, creatinine, and their electrolytes. Okay, so the phases of this, our initiating phase, this can be, so the time from the initial injury, it can last hours or days, so early recognition is key to preventing permanent kidney damage. Most of it can be reversed. I have this place on my nail that's driving me nuts, sorry. Oliguric, that's going to be the oliguric phase. It's going to be when our urine output is below 400 milliliters per day, and we have that retention of our waste products, so our BUN and creatinine are going to increase. Have signs of fluid overload with edema and hypertension, and with our electrolytes, we're going to expect hyperkalemia, hyponatremia, and then some metabolic acidosis. This phase can last about 1 to 2 weeks. The diuretic phase, that's whenever we're going to gradually start to increase our urine output, so you could be putting out between 3 to 5 liters a day. Our kidneys are going to clear the waste, but they're unable to concentrate the urine well. Okay, that's why we're dumping out so much.
you're at risk for dehydration and electrolyte loss, especially hypokalemia and hyponatremia. This phase lasts about 1 to 3 weeks. Recovery phase, your kidneys function is going to gradually improve, your GFR is going to increase, your labs will start to normalize. This can take months up to a year. Okay, so if not caught early, some of these patients can progress into chronic kidney disease. Okay, so etiology, our pre-renal failure, this could be from a decreased blood supply to the kidneys, so hypoperfusion. We can get this from shock, dehydration, hemorrhage, or heart failure. Where a situation where our kidneys are usually normal, but then once they start to get underperfused, we start to go down the road to acute kidney injury. Intrarenal, this is whenever we have a direct damage to the kidney tissues, our nephrons, tubules, our glomeruli. Examples of this can be from nephrotoxic drugs, toxins, ischemia, rhabdomyolysis, and then that glomerulonephritis. So post-renal failure, causes can be obstruction of urine flow. This can be like your kidney stones, enlarged prostate, tumors, strictures. So if I was to get a test question about this, look at the situation it's describing, okay? Are we before we get to the kidney? Are we in the kidney? Or are we after the kidney, okay? And that's going to give you your etiology for this, okay? Nephrotoxins. So a nephrotoxin is our IV contrast dyes that we use for our imaging. It can cause contrast-induced nephropathy. I have a really hard time with that word. So that's when we have that rapid rise in creatinine. Okay. Some of our medications can be nephrotoxins, so our IV aminoglycosides, things like tobramycin or amikacin, can be from chemotherapy agents, NSAIDs, or it could be from chemicals. Our heavy metals, solvents, those can cause direct tubular damage. So we want to assess our baseline kidney function, so our creatinine and GFR, before giving IV contrast ever or before starting them on a nephrotoxic medication. Always encourage hydration to reduce the risk of these things. And another thing I wanted to point out, I don't know if you were taught this in pharmacology, but a lot of your, if your drug is nephrotoxic, it is often autotoxic. So I was taught like your ears are kind of the same shape as your kidneys. So remembering it that way. This is just because they both share like the same elimination pathway. They have similar mechanisms. Okay. Alrighty, moving on to prevention. So, like I just said, checking the GFR and creatinine prior to giving contrast or nephrotoxic medications, following protocols to prevent contrast-induced nephropathy, hydrate before and after, and then we want to monitor our peak and trough levels of nephrotoxic drugs per our institutional policy. Okay, therapeutic measures. We want to treat the cause, support. Sorry, I keep having this like tickle. Supportive treatment, dialysis, and continual renal replacement therapy. So this is a dialysis for unstable patients. So dialysis, it's pretty, it can cause some drastic changes in your vitals. And if you are already unstable, so your patients that, are hypotensive, you can't run them through that regular dialysis. The continuous renal replacement therapy, it's also referred to as CRRT. It is like a gentle slow 24 hours. You're hooked up to this machine for 24 hours a day. But it's going to provide that slow, continuous removal of the fluids and solutes, okay? So this is a machine you're on continuously. It tells you in the name. So this is going to be better tolerated by stable patients because at the slower rate, it's not causing those drastic shifts that the intermittent hemodialysis will. So everything, our blood is going to be be ran through this hemofilter. The excess fluids and solutes will move across it into a collection bag, and then our replacement fluids can be infused to maintain a balance. So this is commonly used in your ICU settings. These people are going to be your patients that have sepsis, multi-organ failure, severe fluid overload, acute kidney injury. We saw this a lot during COVID whenever patients were just too unstable. They'd be ran on CRRT. I feel like there's a certain kind of nurse that loves these, like your type A personality, where they like, everything in nice, neat, orderly things. They tend to love patients on CRRT. I'm not that nurse. Okay, so chronic kidney disease. We're in the home stretch. We're getting there. Okay, so it's the 9th cause of death in the United States. It's our gradual decrease in kidney function. It is irreversible because once our nephrons are destroyed, they are not going to regenerate for us, okay? That's the part of the kidney that once you've wronged it, it's not coming back to you. So etiologies, we have that diabetic nephropathy. That's our most common cause, just due to that long-term hyperglycemia damaging the glomeruli. Hypertension, that's going to cause that vascular and nephron damage. Nephrosclerosis, that's going to be the hardening of our kidney vessels from the chronic hypertension. Glomerulonephritis, that chronic inflammation and scarring of the glomeruli, and then autoimmune diseases such as lupus, okay? So this often progresses silently until we get to more advanced stages. So we want to make sure that we're screening our high risk patient population, so our diabetics and our hypertensive patients. Okay. Pathophysiology, so a large portion of the nephrons are damaged over time, and that damage is progressive and irreversible. We have a couple different stages. Our renal insufficiency, that's whenever we have about 75% of our nephrons lost, so our kidneys can't concentrate our urine well, leading to that mild azotemia, the polyuria, and nocturia. Then we can progress to end-stage renal disease, and that's when about 90% of our nephrons are lost. So when our GFR is less than 15 milliliters per minute, and then it has this other thing. So it's just whenever our GFR is getting below a certain threshold, we will start dialysis or start looking at transplant to have survival. Uremia, this is going to be where our urea and other nitrogenous waste start to accumulate in our blood. This will lead to our multi-system complications. So it's going to cause, neuro-wise confusion, lethargy, seizures. Cardiovascular-wise, we can get pericarditis, arrhythmias, hypertension. GI, we can have nausea, anorexia, and then skin pruritus, that's itching, and uremic frost, that just kind of yellow, gray, glossy, not glossy, shoot, what do I want to say? Yeah, frosty look. I don't, I'll try to find a picture and post that. It's hard to describe. So just realize that your CKD, they're going to have a lot of body systems that are starting to be overworked from this fluid overload, the electrolyte imbalances. Okay. Next, we're going to move to signs and pathophysiology. No, I just did that one. Shoot, I did that again. Okay, I just explained this slide on the last one. I'm sorry. Okay, so signs and symptoms. All right, we have. I'm getting there. I'm hoping that my voice lasts. Um, so we have our fluid accumulation, our edema. Again, looking for that generalized edema, periorbital edema, shortness of breath from pulmonary edema. Okay. Electrolyte imbalances, our patients are going to be hyperkalemic, putting them at risk for life-threatening arrhythmias. Their sodium can be either too low or too high, depending on whether they're in a dilutional state or if they're in a retention state. We'll have hypocalcemia and hyperphosphatemia. These are going to be due to the impaired vitamin D activation and phosphate retention. Okay. If you ever notice your renal patients, I cannot think for the life of me what it's called. They're these blue and white capsules. They're their phosphate binders. Hang on, I gotta look this up. This is bothering me. Okay, that's those phosphate binders. That's your Foslo, the blue and white capsules, or you have those. You're gonna give these with meals, or you have the Renvela or Celevramir. Those are those huge. They look like the potassium pills. They're like as big as the tip of your thumb. They're huge. They have to take a couple of them. But those are going to help with that hyperphosphatemia. So then we have our waste product retention, so our azotemia and our uremia, causing confusion, nausea, itching, pericarditis. We can end up with metabolic acidosis, so looking at the acid-base balance, metabolic acidosis from that hydrogen ion retention. Okay, and then a lot of our kidney patients are anemic just because of that decreased erythropoietin production. Alrighty, so the next graphic is just kind of showing you overall that our kidneys affect so much in our body. Okay. Therapeutic interventions, diet-wise, we want to have them on a high calorie, low protein, low sodium, low phosphate, low potassium diet. They're going to be on fluid restrictions. So our protein, one thing I want you to notice is on dialysis, our protein intake actually needs to be higher. Okay, by doing a low sodium, low potassium, low phosphorus diet, we're helping prevent the hypertension, hyperkalemia, bone mineral complications, the increased calcium we're going to need for help to balance the phosphorus, and then vitamin C, these are lost in dialysis. Okay, so these patients often have pretty strict fluid restriction to prevent the fluid overload, hypertension, pulmonary edema, and heart failure. So this is where a nurse teaching thing you can do, encourage them to use ice chips for the thirst. And encourage good label reading for looking for hidden places of hidden sodium, so like our processed foods. Alrighty, medications. Our typical kidney patient is going to be on a diuretic to help reduce the fluid overload and edema. This is useful in earlier chronic kidney disease, and then once we progress to end-stage renal disease, we don't see a lot of the diuretics anymore. Antihypertensive, so we want these to help control the blood pressure, to reduce that nephron damage. So our ACE inhibitors and our ARBs are used a lot for renal protection reasons. Our phosphate binders to prevent that hyperphosphatemia. I mentioned the Renvela, that's Celavramir, and then the calcium acetate, that's Foslo. Okay, I think those would be two medications to know the name of, to be able to recognize, I know what this medication does. Okay. Vitamin D and calcium supplements, that's going to help with our bone health. Potassium reducers, that can be your calcium gluconate. IV, that's going to help to stabilize our cardiac membranes. Insulin and glucose to help shift that potassium into the cell. And then there is sodium polystyrene sulfonate. It's also called K-exolate. This is going to remove potassium via the gut. This, it's a busy day whenever your patient needs to get this. It causes some pretty significant diarrhea, okay? And then we have that Pituramir, that oral medicine. It's going to bind potassium in the GI gut. That's a safer alternative. This says rarely with the K-exolate on this slide. When I started out on a renal floor, I knew what it was supposed to do, but I didn't know how it did its job. And let me tell you, when it took me a while to get it from pharmacy one time with this patient, and I gave him this K-exolate super late. They were up all night on the toilet. I felt it was a hard night. It was a really hard night. So anytime we are giving these potassium medications, we will want to be monitoring for any EKG changes. Alrighty. Okay, another therapeutic intervention we have is dialysis. This is going to be for to help treat our symptoms of overload. So our pulmonary edema, severe hypertension, shortness of breath. It'll help to treat high potassium so we don't have those life-threatening arrhythmias, neurological conditions. So whenever our patient is needing dialysis, so their body's no longer maintaining that fluid, electrolyte, waste balance, and those wastes are building up, we can see a lot of confusion, possibly seizures. We'll have a decreased level of consciousness due to that urea buildup. Then the uremia, clinical signs of this are going to be nausea and anorexia. Can lead to pericarditis, pruritus, and bleeding disorders. So a good way to remember the dialysis indications is an AEIOU. So the A is going to be acid-base imbalance, E, electrolyte imbalance, I, it says intoxication, so that's just looking at our toxin overload. Overload for the O for fluid, and then U is going to be uremia. Okay, so our next couple slides, I think, are for an activity. It's just a couple. Okay, so our hemodialysis our hemodialysis machine is going to work as an artificial kidney. So it's going to help to remove waste products like urea and creatinine, excess water, electrolytes. What we can do for this, they'll have an access. So it can be a central venous catheter. It's inserted either into the internal jugular, the subclavian, or the femoral vein. This is going to be used for short-term or emergency dialysis. So your non-tunneled catheters that are going to sit in your chest, those are going to be just permanent. Not permanent, temporary. I'm getting there. Okay, so for our permanent accesses, we'll have the arteriovenous fistula. This is going to be the preferred method. So you're surgically going to connect a artery and a vein. They try to do it in the forearm. You may have it up here towards the bicep area. If you don't have great vasculature, they can do it down at the femoral site. So this, whenever your kidney disease is starting to get bad enough, they may go in and start to place one. So to do one of these procedures to create an AV fistula, but it takes a long time to mature. Okay, so just know that you put this temporary catheter in to run them on dialysis until this fistula can mature. A vascular access graft, that's going to be a synthetic tube that connects the artery and vein. This is going to be if the veins that they have just aren't suitable enough for a fistula to be created. So this can be used sooner, but it has a higher risk of clotting off. Okay, our temporary catheters, those also have a higher risk of thrombosis and infection. So a good teaching that we want to do for these fistula or graft sites is to avoid blood pressures. IVs are blood draws on the access arm. The unit that I worked on, these people had been on dialysis for a long time, so they would have, a dead one in this arm, one that was in this arm. So which one do you go to? You're going to preserve their good arm, so you want to go on the one that's dead. If you are in an emergency situation, the physician may give permission for that IV to be placed on that, but these are people that have a lot of the IVs placed in their feet if needed, just because they're really hard sticks. They really are. When we assess a fistula or graft, we want to listen for the bruit and thrill. So our bruit, that's going to be the whooshing sound, and then the thrill, whenever we put our fingers lightly on it, we'll feel that vibration. Okay, and we're doing that to assess patency. We want to do that once per shift. Okay. This picture shows somebody hooked up to a dialysis machine. So here we're showing their access. So they'll need to have some kind of access, whether that's a fistula, graft, or a temporary catheter, central line. The needles and tubes connect to this. We have our blood line, so our red line on there is going to be our arterial line. That's carrying our blood to the dialyzer, and then the blue line is going to return the clean blood back to the patient. Okay, so our dialyzer, that's going to act as our artificial kidney. It's going to be like a filter. Okay, so the blood's going to pass through those semi-permeable membranes, and the waste products and excess electrolytes are going to diffuse into the dialysate. The dialysate lines, that's going to have that solution in there that's going to flow on the opposite side of the membrane and help to pull out the urea, creatinine, excess potassium, phosphate, and water. Okay, so this is kind of a balancing act right here. Our hemodialysis machine, that's going to control the blood flow, the dialysate flow, and monitor our pressures. Okay, this is going to ensure that we have a safe removal. So hemodialysis is typically done 3 times a week. It can be for about 3 to 5 hours a day. Your physician will put in orders on what your dialysate solution should be. They'll put in, goal to take off, 2 kilos and, or liters, sorry. So they have a goal that they want to get to, but also it's not like a hard and fast goal. It's, you hope you get there, but if your patient cannot tolerate it, so if they're getting hemodynamically unstable, you're going to go ahead and cut that run short for them, okay? It is a very, I don't know, it takes a lot of balancing, I feel like, with that one. So this is just a picture of a patient that is undergoing dialysis, so actually seeing the machine that's right there. I know some of you that have been to Cardinal Hill, you've gone in there and looked at the machine. Okay. Next, so the permanent vascular access care. Post-operatively on these, we want to do neurovascular checks, checking for pain. We want to elevate that extremity, verify thrill and bruit patency. Of course, protect the area. We usually have a sign above their bed or on the foot of their bed to protect the access, and we want to also educate the patient on why we are protecting that access. So here's a little graphic that helps us show the difference between the fistula and the graft. So our fistula, that's going to be that surgical connection between the artery and the vein. So the advantage of this, it's preferred for long-term dialysis. It can last several years. It has the lowest risk for infection and clotting. The disadvantages of it, it's going to take a long time to mature. So there's that, and our patient needs to have good vessel quality to actually be able to do one of these. The AV graft, so that's going to be that synthetic tube. So this right here, that connects the artery and vein. It can be used sooner than a fistula, so little as 2 weeks. It's going to be a good option if your patient's veins are too small or they're just too weak. But the disadvantage is we have a higher risk of that clotting, higher risk of infection, and it has a shorter lifespan, so about 1 to 2 years. Okay. Alrighty, peritoneal dialysis. Okay, so this is going to be a therapeutic intervention where continuous dialysis is being performed. It can be performed by the patient. So it uses our peritoneal membrane, so our lining of the abdominal cavity, as a semipermeable membrane. We use these dialysate bags, so they're like big, almost, I think they're 5 liters, to instill into that peritoneal cavity through a peritoneal catheter. So you have this catheter that's coming out of your belly. It kind of looks like a feeding tube, like that's about where it's placed, but it has kind of like a metal connector on there. It did whenever I did this. So the solution is going to flow through that catheter, and then as it sits and it dwells in there, it's going to remove our waste products and any excess fluid. It's going to be moved from the blood into that dialysate by diffusion and osmosis. So the exchange process here, you have this bag, this huge bag hanging up on an IV pole, like on a scale, and then you're going to flow it in. That solution's going to dwell in there for several hours, and then to drain it, you're going to just take that bag that you dwelled out, that you ran all that fluid out, and then just set that bag down on the ground, and you're going to let it flow all out. This is like a your patient needs to be motivated and have the dexterity to do all this. So this can be done at home. That's an advantage of it. It can be done manually, or it can be done automated at night, so you can kind of just hook yourself up to this thing. So that offers more of a independent lifestyle from the hemodialysis. Teaching point of this is you're at a risk for peritonitis. That's pretty serious. They get pretty sick. So you have to be, this is a strict aseptic technique during the exchanges. So you have your sterile field set up. Even whenever you're draining the bag on the ground, you're setting like a sterile drape on the ground. But you'll put, you have the catheter, you take the catheter cap off, and you're putting betadine in there, putting on this adapter, betadine, putting on another adapter. It's a pretty lengthy process. If you can watch a video on it, it's lengthy. So quick little story. One time I had a lady was a brand new nurse. She was on peritoneal dialysis. I was in there with my preceptor, and we were draining what she had dwelling in her, and it was just sludge that was coming out, and it was so disgusting looking, and it just looked like there was this weird stuff floating in it. Like it looked like somebody blew like one of those dried out dandelions, the like white stuff. It was really gross. And so my preceptor got to talking to her, and she was like, "This is pretty bad. Like, how do you do it?" And she was walking her through the process of what she does. And she was like, "Well, it sounds like you're staying sterile. Like, what's your environment like?" And this lady said, "Oh, well, my cat always sits on my lap while I do it." And so what was coming out of her belly was this cat hair that had came into it. It was disgusting. That is like I I can't think of peritoneal dialysis without thinking of the goop that was coming out of that lady's belly. Okay, so here's a graphic where we have that fill. So of course we have it above our patient. We're instilling by gravity, and then to drain it, we're gonna drop that bag down. So something to make note of: if your patient that's on peritoneal dialysis goes into a cardiac arrest, you want to drop that bag. Even if it's not time, go ahead and unclamp and drop the bag down, because you're not going to do good compressions. Well, even if you're performing good compressions, it's not going to give you what you need with that 5 liters of fluid sitting in their peritoneum. Okay. So signs that somebody's peritoneal fluid is infected would be like a cloudy appearance to it. So it should look like a very like pale urine color almost. Study here. And moving to kidney transplant. We really don't have much to go over with kidney transplant. I just want you to know that there are living donors that we can do. So we can have a family member donate a kidney. It's your best outcome to have a genetic similarity, but any living donor would do. Or you can have a cadaver donor. The person's going to be on anti-rejection drugs, so those immunosuppressive drugs. These are commonly going to be our corticosteroids, so prednisone, these calcium inhibitors, that's the cyclosporin or the tacrolimus, and then the anti-metabolites. Okay, that's your CellCept drug. This is going to be lifelong. It restores the function of a normal kidney once it's done, so that's preferred over dialysis. They have a longer life expectancy and improved quality of life, but this needs to be somebody that's going to have strict adherence to the immunosuppressive therapy. Okay, so when you do a kidney transplant, the diseased kidneys are usually left in there unless there's an infection or cancer. Okay, so we're going to just put that new transplanted kidney in there. So, one second. Okay, so things that we want to do to monitor for rejection signs and tell our patients. So we want to monitor for fever, decreased urine output, swelling, tenderness over the graft site, and then a rising creatinine. Our next few slides are several nursing diagnoses. Okay. Alrighty, so I think we're getting, no, we're not. We still have kidney disease or kidney transplant. Okay, so we have a kidney. Then we have our review questions. I think next we're going into prostate, and then we're done. Okay, nursing care of male patients with genitourinary issues. So we're just going to focus on a few prostate disorders. So the prostatitis, benign prostate hyperplasia, so BPH, and then prostate cancer. When I took my NCLEX, I remember having a lot of questions about prostate cancer and BPH, And then also, whenever I took my pathophysiology class this summer, I had a lot of questions on the final about the prostate. Um, so our etiology of prostatitis is going to be, it can be acute bacterial prostatitis or chronic. Um, signs and symptoms, we're going to have a lot of pain, urgency, frequency, dysuria, urine retention, fever, and chills. Diagnostic tests from this, we can do a digital rectal exam, urine culture, cystoscopy, interventions. Our antibiotics, it's normal to use some fluoroquinolones with those. Fluoroquinolones. I can't pronounce anything right now. Okay. We'll use some anti-inflammatories, so some NSAIDs to reduce the pain and swelling and inflammation. Supportive care that we want to do is encourage our patient to use stool softeners to prevent straining, sitz baths to provide comfort and reduce the pelvic muscle tension, and then there's also prostate massage to help drain prostate secretions. So I wouldn't recommend using that if there's acute infection. Lifestyle changes, so dietary changes. We want to avoid bladder irritants, so caffeine, alcohol, spicy foods, and surgery if necessary. Okay, this is rare, but if there is an abscess, you would go for a surgical intervention. Just want to encourage our patients to hydrate to help flush out bacteria, and then monitoring for any urinary retention. So we have some nursing diagnosis. BPH, or benign prostate hyperplasia, that's going to be whenever we have an increase in the number of cells. So we're going to look at signs and symptoms of this is going to be urinary retention, dribbling, nocturia, dysuria, urgency. We can diagnose this by the digital rectal exam again. Our lab tests are BUN and creatinine. Since there's obstruction, this can cause hydronephrosis and cause some renal impairment. The prostate-specific antigen, that can be slightly elevated in BPH, but it's also a screening tool that's used for prostate cancer. There's uremic flow studies where we're measuring the urine flow rate and bladder pressure, imaging. You can do that. You can do ultrasound and cystoscopy. So what we want to know is that BPH and prostate cancer, they can present similarly. So we use that PSA test to help differentiate. Okay. With the digital rectal exam, you want to explain the exam to your patient prior to doing this, okay, and to help reduce any anxiety. Next, for symptom control, we have we can catheterize intermittently, increase fluids if antibiotics are needed, using those. Watchful waiting, what does that mean? When your symptoms are just mild, trying lifestyle changes, so reducing evening fluid intake, avoiding caffeine, alcohol, doing things like that. So regular monitoring without any treatment. The alpha adrenergic so your alpha blockers, that's what these are. That's going to be like your tamsulosin or your doxycycline. So it's going to reduce the smooth muscle in the prostate and bladder neck. And that's going to, did I say reduce? I think I did. Relax the smooth muscle in the prostate and bladder neck to improve the urine flow. Okay, we have hormone blockers, so finasteride and dutasteride. Those are going to shrink the prostate. We have minimally invasive procedures that we could do, so that transurethral microwave therapy, that'll help destroy any excess prostate tissue. Our transurethral needle ablation, that's going to use radio frequency. And then surgery, so a TURP, that transurethral, I think that's on the next page maybe. Yep, TURP's on the next page. Okay, so transurethral resection of the prostate. So you are going to, this is our gold standard surgical treatment. It removes any obstructive prostate tissue via cystoscopy. So, okay, whew. All right. So this is going to be where the surgeon is going to use kind of like an electrical loop and go through and shave off any excess prostate tissue that's blocking our urine flow. Um, it's a bloody surgery. Okay, it's bloody, but it is the gold standard. When our medications and our less invasive procedures fail, the patients after having this are going to be hooked up to continuous bladder irrigation. So that's, I think there's a picture. Okay, so there's a very similar question to this on your quiz. Um, so I would look over this slide right here, okay? When you see an increase of blood and clots inside the catheter collection bag, so your TERT patients are going to be hooked up to this continuous bladder irrigation, which we have a picture of in a few slides. But you're going to assist your patient back to the bed and report changes. What is going to happen is either you need to increase the speed that the irrigation is running. So if you run it too slow, it can clot off, and that's not what we want. We're using the irrigation inside the bladder, so we don't have any clots forming in there, ideally. So if it's running too slow, there's time for those clots to form. If we start to run it faster and we're not seeing those clots coming out, that's whenever you would have to go in and hand irrigate it. So I am not 100% sure if it's within an LPN scope of practice, but to hand irrigate, you're gonna use kind of a what do I want to say, push-pull method with that irrigation, so you can kind of try to loosen the clot. Okay. I feel like there's probably a video out there showing that would explain that better. Okay, so assist the patient back to bed to prevent falls. Some blood in the Foley bag is normal. So a doctor will usually tell you what they want the urine to look like, or what they want their bag to look like. Some will say, I want it like a rosé. Others want it more like a dilute pink lemonade. Okay, so there's a spectrum of what they want. So here is a picture showing our prostatectomy. We can have a few different types. So we have our suprapubic, where the incision is going to be made through the lower abdomen into the bladder. That's going to provide direct access to the prostate through the bladder. Our retrograde, so that one in the middle, or retropubic, sorry, that's going to be where the incision's made through the lower abdomen, but not into the bladder. So the surgeon's going to reach the prostate by moving behind the pubic bone. That's going to allow for the removal of the prostate and sometimes nearby lymph tissue. Our first one, that's going to be whenever we often have like bladder disease going along with it. We'll go that route. So the middle one is whenever it'll allow the complete removal of the prostate. The last one, the perineal prostatectomy, so the incision's going to be made through the perineum. It's less common, but sometimes used if a pelvic surgery is needed. Okay, so if the other approaches are not appropriate, or anatomy makes it impossible, they'll use this approach. but there is a higher risk of damaging the nerve. So you run the higher risk of having incontinence and then erectile dysfunction after. Okay, so nursing considerations that we want for this surgery: catheter care. You're often going to have an indwelling catheter for several days, monitoring for bleeding, especially after the suprapubic approach. Pain management, preventing infections, and then monitoring urinary output and bladder spasms. So, okay, so we have some slides about nursing diagnosis here. I do want to stop on one. We want to monitor their urine output and bleeding, encourage fluids, and teach our patients to avoid anything that's going to cause straining motions. Okay. Acute pain related to bladder spasms. So here's what I want to talk about. Bladder spasms are like a pretty unique pain. With these, we have a suppository that we can give. I'm going to look up what it's called. It's called a B&O suppository, but I know that it's belladonna. But let me look for sure. Okay, so the B&O suppository, it is belladonna and opium, and that helps to reduce the bladder spasm. These are going to be locked up, well, not locked up, in like a narcotic count due to the opium, though. They work by. Alrighty, I looked these B&O suppositories up. So the belladonna, that is going to be your smooth muscle relaxer, and then the opium, that's going to be helping with the pain. Okay. So you want to, a patient may experience a lot of pain and bladder spasms with this. The pain could either be due to the spasming, or if your patient has clotted off inside their bladder, so they have all that fluid rushing in and they can't get any of it out, and so their bladder's just filling and filling and filling. It's going to be pretty painful. So we want to monitor to see if we're actually getting fluid back out, and if it has clotted off, then doing that hand irrigation. Okay, we have another, for the urge urinary incontinence, teaching the Kegel exercises, offering for incontinence the condom catheter pads. So things that we want to teach our patients after our surgeries is to avoid any heavy lifting for 6 weeks, try to avoid stairs, driving, and driving specifically, it's that pushing like the brake, the gas pedal motion. Strenuous exercise, straining, sexual activity, aspirin, and NSAIDs. We want them to report any symptoms of urinary tract infections and report an increase in bleeding. So I think that these would be a good test question for like patient needs further teaching these things. Okay. So here's the setup of the bladder irrigation. So this is continuous bladder irrigation. It'll sometimes be abbreviated as CBI. So you're going to have 2 bags. They're like 5-liter bags of these irrigation fluids, and one is going to be clamped and your other one's going to be open. So you have this replacement bag, so your system here is never running dry. As soon as you're starting to run low, like you're about to run out, go ahead and clamp it, open this one up. Okay, so this is going to funnel into this irrigation port. So you have a 3-way Foley in. So we're going into the Foley catheter, we're irrigating in the bladder, and then it's coming out to the drainage bag. Okay, so this third port, that's that port where you inflate the bulb at. Okay. I would expect to see a question about this, so I would know about it, okay? Next up, okay, so anxiety, prostate cancer. This is going to be our last topic. So signs and symptoms, or no, not there. Risk factors. Okay, so older than 65, high testosterone, high fat diet, family history, occupational exposures. What kind of occupations? So a lot of our farmers and from the pesticides can get this. So farmers, agriculture workers, those chemicals can disrupt our hormone regulation. Okay, so signs and symptoms. We're rare to have symptoms in the early stages. Later stages, we're going to have urinary obstruction, hematuria, urine retention. In our advanced stages, we're going to have bone pain, anemia, weakness, and weight loss. So we have our diagnostic tests, a lot of them that we've seen before, that digital rectal exam, the PSA, that prostate specific antigen. So normal is less than 4, but that's not like a hard normal, okay? It's going to be more elevated though in prostate cancer, okay? So it's one of those lab values that are like certain places, it's the threshold is different. So around about 4, it's not a hard and fast 4. Okay, so that's a useful screening and monitoring tool. The ISO-PSA, that's a newer test. It's more accurate at distinguishing between BPH or between the benign and malignant prostate diseases. Okay, so this is ideally going to help reduce biopsies. We have that transrectal ultrasound with biopsy, a bone scan. So we want to teach our patients that there are screening tools, but biopsy is going to be our definitive answer here. Alrighty, so therapeutic interventions, early stage, we can take testosterone suppressing medications. They're going to lower androgen levels that are going to cause tumor growth, so we want to lower those. If the cancer seems to be very slow growing, it can be that watchful waiting. Later stages, we might move to a TURP or an open prostatectomy. These are not going to be curative for cancer, but they can also all be palliative to relieve obstruction. Okay. Radiation therapy, this can be curative in localized cancer, or if we have advanced disease here, it can be only a palliative radiation used. So metastatic disease, so what's radiating beyond the prostate, so there can be an orchiectomy or estrogen therapy if necessary. That's going to rapidly decrease the testosterone production. An orchiectomy is whenever you're removing a testicle. Okay. Chemotherapy and radiation, that's going to be used when our disease has spread to other bones or organs. And then the radical prostatectomy, that's the complete removal of the prostate, seminal vesicles, and nearby tissue. This is going to be used in aggressive but still operable cancers. So if it's localized, we can do surveillance or the local treatments. If it's advanced, we can do combination therapy, and metastatic, we're going to do the systemic therapy, so hormones, chemo, orchiectomy. Alrighty, last slide, here we go. Okay, last slide. So unrelated to the BPH and the prostate cancer, if we have an acute kidney injury, our creatinine is going to be increased, okay? With BPH, though, that's going to start in the center of our prostate gland where the urethra is located. Urinary symptoms start early in the disease process. Our prostate is going to feel large, soft, and boggy. With prostate cancer, it is going to start posterior and lateral of the prostate gland, and then urinary symptoms are going to start as that starts to move inward towards the urethra. Our prostate with prostate cancer is going to feel normal sized, but hardened. Okay. I just want to go back to the continuous bladder irrigation for a minute. So whenever we would see that patient from that activity standing there and there's the bags looking, pretty bloody, we assist them back to bed. So from there, we're going to have kind of an assessment process. If they're complaining of fullness in their bladder, we want to check for any clotting. So does it look like we're having anything coming out to the drainage bag? We see that the irrigation bag is running freely in. Okay, that's running freely in. Do we have any output, or is it all just being stuck in the bladder? So if it looks like it's all being stuck in the bladder, then we would do that hand irrigation, okay? That or manually irrigate. Maybe I should have said manually instead of hand irrigation. Manually irrigate, okay? That agitation from that manual irrigation is going to help break those clots loose. If we notice that, we have it running in and then they're complaining of fullness and we have that super bloody urine running out, so we know that we have output out of the bladder, we're going to be concerned for hemorrhage, okay? So we're looking at, are we draining? If we're not draining into that drainage bag, then we need to irrigate, okay? I like that slide. I feel like it does. It's a good training for you, okay? As always, if you have any questions, if you stuck with me this far, email me. Working on the breakdown of this, I think our adult urinary lecture is taken about twice as long as our pediatric, so I would expect like a 70-30 split probably with the questions, so 70% being adult, 30 being pediatric. So that's how I would manage your study time with this, okay? I will be putting out a blueprint though for the entire final exam. Alrighty, so email me if you have any questions. Thank you.